Hi guys, good morning. Welcome back to my channel. For today's video, I just wanted to do a video basically on how I receive handoff report. I've been seeing a lot of these videos floating around, and I thought it was very interesting how each nurse takes report differently. For those of you who don't know, I am a registered nurse. But it's interesting to see the different techniques and, different quirks that each nurse do. I mean, overall, the big picture is the same, but just little notes that each of us write down, I think it's interesting to see. So I wanted to film this video to give you guys a look into my nurse brain and to show you how I receive report and how I kind of streamline all my patients. So I wanted to give you guys an overview. Basically, at my hospital, our ratio could be 4 to 5 patients, and sometimes we do get 6, but for the most part we've been pretty much good with 5 patients, I would say. I don't want to put it down to 4. 5 patients. Sometimes I do get 4 patients, but if I start off with 4 patients, I anticipate getting an admission. So I would say 5, but like I said, sometimes we can get 6. So that's just I think that's standard at most hospitals. So I just wanted to show you. I'm just going to do it basically on one patient. It's what I do for each patient, but I'm not going to sit here and do it for 5 different things. And granted, we don't have no patients here, and this is just going to be a made-up patient. So if you're interested in this video, please keep on watching. Sorry guys, I don't really have a way to anchor you guys so you can see, so this is the best that I can do. But basically, you start off with a blank sheet of paper. I usually turn on the back of my report sheet because my job do give us packets on each patient when we arrive. So I'm on the 4th floor, so usually I start off each report by putting the room number the patient is in. So for today, I'm just going to put 4th floor. So I do 4th floor, and then I will put the patient's name. So today we have Jane Doe, who is a, let's just say she's a 47-year-old female. She's a full code with no known allergies. Okay, so I'll start off like that, and then I will basically go right down the systems. I'll go down each system, and hold up, sorry. Okay, so I basically go down the system. So while my colleague is talking to me, she will give me an overview of the patient. So Jane Doe came in for a small bowel obstruction, let's say. She came in for a small bowel obstruction, so she has abdominal pain and experiencing nausea, vomiting. Okay? So that's the overview. Let's just say she has a history of diabetes and hypertension. Okay? So I've already gotten that in the report. So now my colleague is going to go down the system. So they're going to say Jane Doe is alert and oriented ×4. She's on room air. She has no edema and no chest pain. They're going to tell me her last BM was yesterday for the BM. And they're going to say she is a self-care. Her skin is intact. She has a right AC 20 gauge, and she's getting normal saline. Well, she's gonna be obviously at my job. See, I'm thinking now, because at my job, I just generally, if somebody's come in with abdominal pain, nausea, and vomiting, they're gonna be NPO. So her fluids will probably be, let's say, D5 normal saline at 100. That's just because I want it to be as accurate as possible. So her fluids will be D5 normal saline at 100. And she is a finger stick, so she's going to get her finger sticks 3 times a day before meals. For pain, she gets morphine, 2 milligrams, Q4. Labs have been drawn. I always ask if the labs are drawn or if she has like a central line. But she doesn't have a central line. But if she had a central line, I'll ask the night nurse, did you draw the 6 a.m. labs for today? And then the plan for today, maybe her plan is to do EGD. So that is pretty much how I do an overview of my patients when I'm receiving report. And then I will go through and I will check for any abnormal labs. You know, I will go into the chart and I'll check for any abnormal labs if the night nurse didn't already mention it. So I will check her, you know, her H&H. I will check for, you know, BUN, creatinine, all those labs. But anyway, once I sit down and I go into the chart, the first thing that I look at is I go in and I look at the 9 a.m. meds. So we do pass meds at 9 a.m. I worked at a last hospital who passed at 10 a.m. So I look at the 9 a.m. meds, and these meds I actually do take the time to write down because this tends to be the most medications that I pass in the day, like at a single time. So I can just kind of like to streamline it. That way when I'm pulling them from the Omnicell, I don't forget any or, you know, get confused. But let's just say if she has a history of hypertension, I'm sure she'll be on some type of blood pressure medication. So let's just say she's on amlodipine. Okay, so then seeing this, I know that she is, I'm gonna have to know her blood pressures before I give. So, you know, let's just say her trend is, I don't know. I'm just making up numbers now, y'all. Let's say 74, 99% on air. She respiration is 18 and her temperature is 36.8. We do our temperatures in Celsius. So we will get her vitals. I will look at her trending vitals, but I still will make sure that I take a current vitals before I give the medication. And then, you know, she's NPO. Sometimes they'll put the orders accept meds, which is most of the time. And usually before a patient will go for a procedure, if they're going for any procedure, the night nurse will probably give the blood pressure medication beforehand. But everything else, that, like, let's just say she's going to get her blood pressure medication, but I'm sure they will order some type of Pepcid. And Pepcid can be given IV. It'll either be Pepcid or Protonix. I already anticipate having that on the chart, and that will be IV. And I don't know what else they would give. I'm just streamlining here because this is all off the top of the head. But and then I'll look at her PRN orders. She came in with complaints of nausea and vomiting, so most likely I would see Zofran on the chart. I would definitely see a Tylenol on the chart. That's probably like a standing order at every hospital. And then since I know she's getting morphine, I see morphine as a PRN. And they'll probably have maybe a Benadryl just in case she gets some kind of itching from the morphine. But that's usually what you will see in PRN orders. Oh, and milk of magnesia. So that's what I'll do. And I'll pull my meds and then I'll go in and I'll see I've already introduced myself, but I'll go back into Miss Jane Doe's room and I'll just go ahead and do my initial assessment because this was given to me by the night nurse, but it is very important that you do your own assessment of the patient because there's been times, and I'm not shading anyone, but there's been times where I've been told that skin is intact, then you turn the patient over and they have a stage 2 ulcer on their bottom. So, you know, or there have been times where I would get a patient and they say that she has a stage 2 and it turns out to not even be a stage 2. It was just a skin tear. So I have been rounding with my wound care nurse at my hospital. So I've been trying to get more equipped with wounds and doing wound care and changing the wound vac. So I've been really particularly interested in wounds and staging wounds. And that's why I just went off on that tangent. But that's pretty much basically what I do after 9 a.m. If she is a diabetic, we'll probably check her finger sticks again at 11:30. And then we'll give insulin if she's on insulin. If she usually takes metformin, the doctor will probably have her on metformin. But half of the time, they usually do Novolog at my hospital. And just for the hospital stay, they'll give the patients Novolog. And sometimes for the 9 a.m., she might even get a Levemir, the long-acting insulin in the morning. So I'll do that, and then pretty much that'll start my day. I will go over, and then I think it's very important to also look at the doctor's report. At this early in the morning, the current doctor probably hasn't written a report because he hasn't rounded on the patient yet. But it's good to look at the one from the day before. And also, I would say with Miss Jane Doe, you might want to, at my hospital, we have teams. So they have team A, B, C, D. And they give us a list of the doctors assigned to each team. So usually I will look for the team. So let's just say she's team, I'm going to say team P. And then her doctor, I'll know who her hospitalist is for team P. So I'll write the hospitalist name. So I'll know who to contact if anything goes wrong with Miss Jane Doe. Like, let's just say she snuck crackers at 6 a.m. So I'll know, okay, I have to call the hospitalist and let them know that she has not been NPO since midnight because she ate crackers. What do you want to do? Do you want to still do the EGD, or do you want to, postpone it, push it back a time or something like that? So yeah, always make sure you know the hospital is covering the patient, because you don't want something to happen and then you don't know who to call. I do work on the orthopedics floor, so this probably will be the med-surg floor, but this will probably be the med-surg side of my floor. But if I was to work on orthopedics, let's just say Miss Jane Doe is not here for small bowel obstruction. Let's just say she had a total knee replacement. I would know it won't be a hospitalist assigned to Miss Jane Doe. It will be the direct surgeon, and maybe I had to look for the resident on call, or they always have a PA that is local, and she's pretty good. I'll call her direct because I have her direct extension. But it's just different avenues for each type of patient that you'll know who to call. But basically, that is a look into my nurse brain. It's not really, I've only been a nurse for 2 years. As I go throughout my day, I start reading like previous notes and reports, and everything that is involved in the care has been involved in the patient's stay, the care for the patient's stay. But right in the morning, this is pretty much what I do. And then I wanted to make mention that our job incorporated something called purposeful rounding. So you have to check on the patients, I think every odd hour, just to see if they're in pain, if they need to go to the bathroom, if you can get them anything. So I pretty much round on all my patients all the time. So this is just the first initial step when I get to work. I hope somebody found it helpful. I know I'm a bit of a mess. I'm only a 2-year-old nurse, so this is basically what I do. I'm sure as the years go by, I'll get better and better. But thank you guys so much for watching. Let me know what you want to see next, and I'll see you in my next video. Thank you. Bye-bye.